Today it is going to be from surgery. So all of you, you can, if you want to answer, you can unmute yourself and you can answer it. Okay. So let's start with first one. What in the GCS score, what score will you give for decorticate posterior?
3. M3.
2.
M2.
3. M2. 3.
3.
Remember
M3.
2 is extension, shoe ka extension. 2 is shoe extension. 3 is sitting under the tree in abnormal flexion.
Cerebrate is extension.
Decerebrate has all E in its spelling. It is abnormal extension, and decorticate is the abnormal flexion. So when I say decorticate, it's going to be M3, and decerebrate is going to be M2. So logically thinking, which is more worse, decerebrate or decorticate?
Decerebrate.
Decerebrate.
Because they're giving a score of M2, right? A lower score. So that's going to be worse, right? Next one. When you have a patient, a patient of trauma, thoracic trauma, you have done thoracostomy. Now, on basis of the drain output that is coming, what is that measure, that quantity? It tells you that if the drain is more than this much, then you go ahead with surgery, thoracotomy.
200 ml for 3 hours and 1500 ml in first.
1500.
Absolutely right. The first drain which is there, if it is more than 1500 ml, right, then it is, you go for surgery. And if it is more than 200 ml per hour for 3 consecutive hours, then also you go for thoracotomy. Great. And what catheter size do you use for it, the drainage now?
24.
28 to 32.
28 to 32.
28 to 32. Previously it was 36 to 40, but now it is said that 28 to 32 is what should be used. Correct. Next one, what is the name of the surgery done for thyroglossal cyst?
Strong procedure.
Correct. Remember thyroglossal cyst. Cyst is cyst trunk. That's how we remember. Cyst trunk. Thyroglossal cyst is a midline swelling, right? That moves with
Deglutition.
both deglutition and trunk protrusion. Then you have, if there's pelvic fracture, what part of the urethra is generally injured in pelvic fracture?
Membranous.
Membranous. Remember pelvic fracture, P for P, pelvic fracture mein uske paas aayega posterior urethra, and posteriorly you have the membranous urethra. Bulbar urethra is generally injured in what injury?
Straddle.
Correct. And what part of urethra is a part of a deep perineal pouch?
Membranous urethra.
Membranous. And that is when membranous urethral rupture, you would see that fluid accumulating only in that deep perineal pouch, while the bulbar urethra one will go into the scrotum, the penis, the entire anterior abdominal wall. Okay. All right. Next one. What suture material will you use for hernia mesh?
Proline.
What is the mnemonic to remember proline?
PRO.
RO. That is P for
Pipes.
pipe. That is R for
Rectus sheath. And omphalocele.
O for omphalocele or hernia repair, right? So that is why hernia repair jab aayega to proline. So remember proline is PRO, pipes, that is vascular, R for rectus sheath, and O for omphalocele, that is hernia. Next one that we have is in patient of acute pancreatitis, the discoloration seen in the flank is called as what sign?
Grey
Turners. And the central one, periumbilical, is
Cullen's.
So remember, center C for C is Cullen's, and we turn on the flank. So Grey Turners is in the flank. Turn on the flank. So Grey Turners is flank. And are these signs specific for pancreatitis?
No.
Retroperitoneal hemorrhage.
Correct. It basically indicates retroperitoneal hemorrhage. So can be seen in ruptured ectopic, ruptured aortic, abdominal aortic aneurysm as well. Okay. Next one. What IV fluid will you avoid in a patient of head injury?
Dextrose.
Very good. Dextrose. Why dextrose?
Because it
It causes cerebral edema because it becomes hypotonic
Correct.
after a while.
So after what happens with 5% dextrose is the dextrose is getting utilized. So what remains is only the water. So that means it is hypotonic fluid, and hypotonic fluid will lead to cerebral edema, which you do not want in a patient of head injury.
Yes, ma'am.
So you can use isotonic or you can use hypotonic also, but not hypotonic fluid. So that's why dextrose is not used. Next one.
मैम एक डाउट है मैनिटॉल cerebral edema के लिए ड्रग ऑफ चॉइस है पर इट इज नॉट यूज्ड इन एक्टिव cerebral hemorrhage नो
हाँ ट्रू करेक्ट, अगर एक्टिव हेमरेज है तो तब हम यूज नहीं करते. So you are asking me the reason for it?
नो
No, this is a true
just
statement.
clarify.
Just say, हाँ तो अगर cerebral edema में drug of choice पूछा तो mannitol है, but if the question says कि but there is active or bleeding that is going on, then in that case you will not use. Then it is contraindicated.
Okay.
Okay. Teloxane is seen in
Chylomympatic
Mesenteric.
correct mesenteric cyst, of which the most common is the chylomympatic cyst, right? And what is the teloxane?
Perpendicular
mesentery के perpendicular
motion.
Correct. So if this is a mesentery that you have, the mesentery base, and if you have a lesion, a swelling here, it moves perpendicular to the mesentery direction, and that is suggestive of a mesenteric cyst, and this is called as teloxane. Most common is chylomympatic cyst. What is the most common anal fistula? Intersphincteric, transsphincteric, suprasphincteric, what kind?
Transsphincteric.
intersphincter.
Inter and trans?
Transsphincteric.
Is intersphincteric, which is the most common. You remember it by the frequency as well. The mnemonic you can remember is it's extra. So I for intersphincteric, then T for transsphincteric, S for suprasphincteric, and again then E for it is extrasphincteric. So it's extra. So the most common is going to be intersphincteric. Okay, that's intersphincteric. Next one, what fluid will you give in electrical burns? How much fluid?
4
ml per
total
surface area.
For adult, it is 2 ml.
Is what you would calculate. 4 ml per kg per burnt surface area is what you have. Otherwise, routinely we use how much?
2%.
2 ml per kg.
This is to be given total in how much duration?
24
hours.
24
First half in 8 hours and then next in 16 hours.
And other half in 16.
Half in 8 hours and second half in 16 hours.
Next half in 16. Absolutely right. So all of you know that. Very, very important. These calculations are frequently asked. So the initial 8 hours, it has to be fast resuscitation. So you give half in the first 8 hours. And then in the rest of the 16 hours, the rest half is what you will give. Next one, what is that name of the classification that is for the endoscopic classification of bleeding peptic ulcer?
Forest classification.
Forest. And what is that classification or scoring which tells you about whether the patient needs immediate blood transfusion in a patient of same bleeding peptic ulcer? The emergency may you evaluate the patient, basis the various parameters, and you decide whether the patient needs immediate blood transfusion or no. What is that score? और कौन से scores हैं classification है peptic ulcer के लिए? No, it's not Rockel. It is Blatchford score. Remember, it is Blatchford, BL, blood transfusion need in emergency. That's what it tells you. Rockel or Rockall is based on, is it Rockel is based on clinical findings, endoscopic findings, or both?
Endoscopic.
Remember it like endoscopic is forest. EF, endoscopic is forest. Blatchford, BL, blood transfusion need. And then you have Rockel is rock all. So it is all, that is clinical plus endoscopic. Both parameters are included in rock all. Right? So that's how you remember your classifications for bleeding peptic ulcer. Next one, is it true or false that medullary thyroid cancer, it takes up radioiodine?
False.
False, because the concept is medullary thyroid cancer comes from parafollicular C cells. It is not the follicular cell. Iodine will be taken up in the follicles, not in the parafollicular, the stromal cells, right? So that is why it will not take up radioiodine. And classically it shows presence of what on histopath?
ACAL.
Amyloid calcitonin, right? ACAL, calcitonin. And does it also secrete serotonin?
Yes.
Remember serotonin also, and that is why patients with medullary thyroid cancer can have diarrhea as well. Okay. So remember that. And the next one is when you have this minimal access surgery in extra, we have discussed this, right? The in vitros for minimal access surgery, right? The various steps which are there for minimal access surgery. What do the two eyes stand for? The first eye and the second eye in vitro.
Insufflate and identify.
Okay.
Identify.
Insufflate and identify, or insufflate and incise, or inspect and incise. You have the various options.
Insufflate and identify.
Insufflate and identify.
Correct. It is insufflate and identify, right? So first is insufflate, right? Insufflate करते हैं, gas डालते हैं laparoscopic surgery में, and then you have insufflate, right? Then you will have visualize. What do you have next? Identify. Then
Identify. Triangulate.
Tract, right? Triangulate करो, yes, the landmarks which are there. Then you did tract, and then O for
Operate.
then S is for
Seal.
Hemostasis.
Right. So that is in vitros. Remember, it's insufflate and identify, not incise coming in here. Next one. What gene mutation do you commonly see with the basal type breast cancer?
BRCA1.
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 BRCA1
Remember, basal
is
type is basically triple negative breast cancer. Basal is like, imagine it's like the baseline, nothing positive. So it is triple negative. So none positive, none is one. That's how we remember. So BRCA1, none positive, that is triple negative. And how do you treat triple negative breast cancer?
Hormonal replacement.
You will have to give chemotherapy, right?
Radiation.
PR positive, so no hormonal therapy will help you, or you'll have to give chemotherapy, right? For a triple negative. Correct. Next one, in Southampton grading, right? Wound jo hai uska classification ke liye, if there is a clear discharge coming from the wound, by clear discharge we mean it is a serous discharge, hemoserous discharge, it's not pus. So what grade is it? Southampton grade?
3.
Correct. 3.
CA.
Correct.
3.
C for clear, C for third alphabet 3. So clear discharge is grade 3. Grade 1 is
Erythema.
grade 2.
Inflammation.
Inflammation.
Grade
Edema
3,
plus inflammation.
clear discharge. Grade 4.
Foul smelling.
Correct. So we have discussed this in one of our previous TNDs, right? The trick is grade 1. 1 for A for erythema. That is how you write erythema, start with A. 2 for inflammation. When I say inflammation, TION, remember the TO2 at the end. C for third alphabet, clear discharge, and 4 for foul. Foul discharge, that is pus coming in, then it is going to be grade 4. Right? Grade 5 is like a deep wound which is there. So that was Southampton grading. Then you have MELD score, the original one. What are the 3 components in MELD score?
TBI.
Bilirubin.
Correct. MELD is end stage पे जो score करते हैं, right? So remember, in the end comes CBI in any investigation.
Yes.
So creatinine, bilirubin, and INR. And what has been added now?
Sodium and
Female sodium level albumin.
Correct. Remember, FAN has been added. So female
Yes, ma'am.
sex, albumin, and N for sodium, Na, sodium, right? FAN has been added, female albumin and sodium. Next one, what is Miami criteria for?
Less than 50%.
Correct. And what is the criteria? How much should it be?
50%.
Less than 10%.
in 10 minutes fall is half.
10 minutes.
Correct.
More
7
than
to 14
50% fall in
More than 50%.
Criteria basically is for when a patient is undergoing parathyroid surgery for parathyroid adenoma, whether it's successful or not, adequate or not. So you have Miami criteria because the parathyroid hormone has a short half-life of 3 to 5 minutes. So the criteria says that in 10 minutes, right, the fall should be more than 50%, more than half of the preoperative level of the parathyroid hormone levels. So it's more than 50% in 10 minutes. Okay, that is adequate. Next one, what is the investigation of choice for posterior urethral valve?
MCU.
MCU
MCU
or
or USG?
No. No.
RGU or MCU? Tell me.
RGU.
MCU.
MCU.
RGU, ma'am.
RGU.
Please do not, it's confusing. I know that when I say posterior urethral valve, you think that it's a
MCU.
urethral pathology
MCU.
RGU, but not RGU. Understand the concept. The valve which is there in posterior urethral valve definition means it's one-way opening. So this valve, it does not open when the urine, the fluid is coming from above, but if you come from below, right, from the urethra, this valve will open. So the direction of opening is towards the bladder from below upwards. So when you do RGU, the contrast is going from below upwards and the valve will open. So you will not visualize any obstruction. But when you do MCU, in MCU, you fill the bladder with contrast and the contrast comes from above, like how we micture it. So that is why you will see that valve not opening and the posterior urethra getting dilated. So it is MCU and not RGU. Please remember that. That is the investigation of choice for posterior urethral valve seen in a male child. It will have oligohydramnios antenatally. You can see it antenatally as well. And the management is going to be this
Pulverization of the valve.
correct. Pulverization of the valve is what you'll have to do. Correct. Next one, what is the name of the surgery done for Peyronie's? Peyronie is where there is penile fibrosis, and that is why you will see the deviation of the penis, which is going to be there, and we do Nesbit surgery. Nesbit is where you do a bit of the penile tissue, right, and we straighten it. So remember, Nesbit is done for Peyronie's. And what is Lord and Jabole procedure done for?
Hydrocele.
Lord and Jabole is done for hydrocele. And where do you have the Barley fluid?
Spermatocele.
Spermatocele. Correct. Spermatocele. And Chinese lantern pattern of
Epididymis.
Chinese lantern, C for C, epididymal cyst. Epididymal cyst will have Chinese lantern pattern. Right. So that was about the today's rapid fire, guys. As always, you were amazing. Anything, like I say, if you realize कि मुझे याद नहीं था, please revise that part retrospectively from your notes. And there was one message from Ira. Sorry, I saw the message, but I did not want to break that continuity in rapid fire, so I did not reply there. So I'm glad that these Medconnect sessions, YouTube motivation shots are helping. Really glad to know that. And it's absolutely fine if you are not able to, follow the schedule. Whatever best you can do with whatever time you have, please keep doing that. Okay, that's the most important thing. And right, the exercise that I was talking about is, so from tomorrow, I want at least one of you to speak about, so you have to be conscious now every single day, and you have to observe that what is that one thing that, at the end of the day, evaluate it and realize, and let us know the next day morning in the Medconnect session. What is that one thing that you were grateful about today, or you were happy about today, or you were proud about yourself today, like something like you felt like not doing this, I'm tired, I'll not do, this part of my study, or maybe you were distracted, but still, with conscious efforts, you took a step. So please let us know, because, when you see your peers also, facing the same feelings, but how they overcome, it actually motivates everyone. And gratitude is something, which brings instant mindset shift, from focusing on what is lacking to, what we are blessed with. So at least one thing that you can be grateful about in the entire day, right? Or one thing that you are proud about yourself is what you have to share tomorrow. So if none of you would volunteer, at least मैं रोज एक जन का नाम लेके बोलूंगी कि tomorrow आपको तो बताना है. Apart from that, others can also participate. So there are, few names which I see constantly in the Medconnect sessions, and I've got, accustomed and familiar with those names. So to begin with, Sandesh, tomorrow you will start for sure. So you have to be conscious today कि कौन सी अच्छी चीज हुई या कौन सी चीज है I've been grateful about. It could not be about today, or it could be about any of your life incident as well. We would like to know about it, right? So Sandesh will start, and if anybody else wants to participate as well, you will speak about it, right? Okay, so today it is Sonia's birthday. That's amazing. Wish you a very happy birthday. from all of us, Sonia, and always stay blessed, happy, healthy. That is what we all pray for you. COPD का treatment, ठीक है. Stack between 110 to 120, no matter what I do. ऐसा देखो हो ही नहीं सकता कि no matter what you do, the scores are not improving. What must be happening is what you are doing might not be the right thing that you are doing. So you have to, get back to first analyzing ki where am I going wrong. Uske alawa, there is no option, right? Until and unless you know that where are you making mistakes. So सबसे पहले step है evaluate yourself on the basis of PYQs. Any PYQ custom module you solve and see that whether you are getting 100% correct there or not. That has to be your primary motive now. उसमें आप गलती कर ही नहीं सकते. Okay, so that's your primary priority now. And then again evaluate whether there's any subject I'm particularly weak in. Please focus on that. I'm lacking in concepts. Please focus on that. I'm lacking in recall. Please do more revisions, right? Or it is I know the fact, I have the knowledge, right? But when it comes to MCQs, then I mark the wrong answers, right? Only when I review, then I realize, oh, this is what it had asked and I already knew. So that means, your MCQ skills have to be developed. So for that, watch all the TND sessions in the Medsynapse app that we have, right? So that's what you have to do. ABCD saying gave the mock test yesterday and improved score, but did so many recall and silly errors. Agar you are doing errors from short and extra edge wala part, that is something that you cannot do at all. Because in the short and extra edge, I've given only the bare minimum content that is required. If you see, it is not everything from all the subjects, but it is what is the most important from all the subjects. So if you still feel ki short and extra edge mein se I'm making mistakes, please keep revising it. Dedicate your time, just half an hour at least every single day, to develop the visual memory of from wherever you are doing short and extra edge. It could be the annotated PDFs, it could be the magic book, it could be your own notes, whatever it is. You have to develop visual memory for that, right? That is something that has to become very, very reflex recall. Okay, that's a bare minimum. So just, focus on more revisions and you shall be good. Silly errors tend to happen in the final exam as well. Right, so get that acceptance ki thodi bahut silly mistakes final exam mein bhi hogi. All that you can do is just being more cautious and careful. That's it.